Immune cellular responses are implicated in all clinical aspects of kidney transplantation, but there are little data regarding the additional value of regular monitoring of immune cell phenotypes expression in the circulation of kidney transplant recipients. The aim of our prospective study was a longitudinal follow-up analysis of immune cell subtypes, including monocyte subpopulations, natural killer cells, and acquired immune cells, including regulatory T cells or Tregs, in the circulation of kidney transplant recipients and potential clinical correlations. So far, there are very few data in the literature regarding monocyte subsets, so we know that they are affected in terms of immunosuppression only by steroid intake, which is associated with higher total classical and pro-inflammatory monocyte counts, but fewer non-classical monocytes. On the other hand, the cellular subsets of the acquired immune system have been studied mainly in terms of allograft rejection, thus lower levels of natural killer cells and subtypes have been observed in patients, oversensitized patients, with positive donor-specific antibodies and PRAs. On the other hand, CD4 positive T cells lymphopenia, lower B cells, lower T regulatory cells, and higher terminally differentiated CD8 T cells have been associated with all kinds of kidney allograft rejection, including subclinical rejection in kidney biopsies. Thus, we included in our study 48 stable kidney transplant recipients. All patients were under triple immunosuppressive regimen, including corticosteroids, MMF or MPA, and the calcineurin inhibitor, less than half on cyclosporine and more than half on tacrolimus. Exclusion criteria included history of acute rejection, cardiovascular disease, malignancy, autoimmunity, and active or chronic infections. Clinical and laboratory parameters were recorded at baseline, T0. Patients were then prospectively followed, and clinical and laboratory parameters were recorded at 12 months, T1. Patients who developed acute rejection during follow-up, new-onset cardiovascular disease, malignancy, or who were hospitalized during the follow-up period were excluded. The peripheral blood immune cell subsets were measured by flow cytometry at baseline and after 12 months. Thus, we measured the CD14 double positive, CD16 negative, or the classical monocytes, the CD14 double positive, CD16 positive, or the intermediate or the pro-inflammatory monocytes as regarded, and CD14 positive, CD16 double positive, or the non-classical monocytes, both absolute values and percentages out of total monocytes. In addition, we measured NK cells, absolute values and percentages, as well as all lymphocyte subtypes, B cell, CD4 T cells, CD8 T cells, and T regulatory cells. 40 kidney transplant recipients were finally included in the study analysis. The mean eGFR declined from 58 ml per milliliter to 53 ml per milliliter during follow-up. No significant changes in spot UPCR or inflammatory markers were observed between T0 and T1. Overall, there was a decrease in mean monocytes counts and mean lymphocytes counts. The mean counts of the classical monocyte subtype increased at T1 compared to T0, where the rest immune cell subsets did not show any significant changes. CNI blood levels displayed no significant changes during the follow-up period compared with baseline. Significantly, a greater increase in the difference of the pro-inflammatory monocytes counts from T1 to compared between T1 and T0 were associated with a greater eGFR decline. The results of our studies suggest that greater increases in levels of pro-inflammatory monocytes are associated with increased early graft function loss, and future research studies with longer follow-up, as we are conducting now, are required to specify the role of immune subpopulations as potential prognostic markers in kidney transplant recipients.